Dr. Mays, thank you for joining Contagion. Really appreciate having you on.
My pleasure.
So, before we get started, could you tell our audience a little bit about yourself, what you were doing before the pandemic started, and how things have changed?
Sure. Vickie Mays. I'm a distinguished professor in psychology here at UCLA in the Department of Psychology. And I'm also a distinguished professor in our Fielding School of Public Health and Health Policy and Management. I'm traditionally trained as a clinical psychologist who also has this public health background. Um, and I'm very interested in issues of integrated care. So I'm interested in mental health being integrated right into primary care settings. Before the pandemic, one of the things that I've always done, so once the pandemic hit, I stepped right up, is I have a background in responding to disasters. So I spent about 5 years funded by the Kellogg Foundation helping to rebuild the mental health system in New Orleans after Katrina. I've worked in several other kind of um, situations in which it's either an epidemic or a disaster. One of the areas of my research that was an area of my research for a long time was HIV/AIDS. I was in it at the beginning of the epidemic. And so part of what I'm doing now is very parallel to the kinds of things I did in terms of HIV/AIDS. There are some similarities there in terms of the ways in which the epidemics are going and kind of the things that we need to do. So I kind of had an experience of stepping into the onset of an infectious disease with the need to understand behavioral interventions to deal with an infectious disease.
And that's interesting too, because some of the interventions might not be as obvious as it seems. For example, if there's talk of, if you had shut down the bathhouses during HIV, I mean, that just kind of spreads it elsewhere rather than actually stopping transmission through protection, stuff like that. Can you talk to maybe some of the parallels in terms of interventions that we're seeing?
Sure. One of the interesting things is that in both the HIV epidemic as well as what you're seeing right now in terms of this pandemic, behavior is critical. So right now, everybody's getting a little freaked out because we're talking about quarantine fatigue, for example. So in some places, people have been, asked to stay inside for like 6 weeks, 7 weeks, probably in the New York area, California, where I am. Other places, it's less amount of time, and the weather's starting to change. And so the issue of confining people really requires at some point realizing that that's a behavior that has stages to it. So you can't just keep repeating the same message of stay home. As much as you have to now have a communication to really assist people in kind of this, elongated phase where you have some people saying, returning to normal and things like that. And people begin to engage in behaviors and take risks that are different than what the reality might be of actually getting infected. So if you're going to have people out, then it becomes even more important that what happens is that they're solely engaged in these protective measures. That's behavior. So you really have to think about messaging people in ways in which you can really deal with their behavior.
I think that's a fantastic point in terms of that it's a matter of risk stratification, right? So the
Yes,
question
it
was
is.
never, are we going to be locked down in the exact same level of social distancing until there's a vaccine? It's a question of, all the stuff we talked about with ICU capacity and then gradual behavioral change. And if you give people an all or nothing choice, they're going to choose nothing.
Exactly. So even now, what you have to think about is the information that you want to give to people is information where what you're doing is assisting them in their behavior, not necessarily just saying how, that it's open, but and you can't just keep saying wear a mask, wash your hands. You really have to say to people, think about what is 6 feet distance look like. So you help them when they're out to understand that. So you start to say, like, this is an example of something that's happening in my neighborhood on nextdoor.com. So they say, if you're a runner, run on the grass or run in the street. So they're actually helping people very quickly not have to figure out, am I 6 feet away from you if I walk on this side of the sidewalk and you're in that side of the sidewalk? No, they've been given a very definite way to, be outside, behave in a way that reduces risk, and at the same time be able to do what it is that they're loving to do, which is they want to run. Even though when they're running, they're sweating, they're, breathing very hard. But instead, what you do is you really assist people with communication where they get it. And if they don't get it, other people know. So if I see you running and you're not going to go on that side, well, then I'm going to go in the street. But it's that visualization, it's those help aids, it is establishing. And this is what happened in the San Francisco area when the epidemic was at its height, and they were like, well, how did this community of gay men, how were they able to really reduce the transmission? Part of it was just establishing social norms. So if you were in that community, it was frowned upon that you engage in certain behaviors, not use a condom, engage in behaviors that were high risk. We have to do the same thing here, which is give people a sense of, if we're all out walking along the beach together, here's my expectation of what your behavior is to be.
I wanted to double back a bit to, you mentioned you had worked on disaster recovery with New Orleans. And I had earlier spoken to, this was right when the pandemic started, the quarantine in Hubei province, China, was still going on. And I spoke with an American physics teacher who was there abroad, who was talking to me about his experience being locked down. And he compared it because he was from New Orleans. And he said he had felt a lot of similarity in terms of the interruption of daily life. And so it was really interesting to hear his psychological reflections, because also in Hubei, there was a lot stricter in terms of the measures that were taken, and probably the psychological toll in terms of, a limit on the number of times you could leave certain apartments, things of that nature. And what the one difference he highlighted, and I'm curious your thoughts on this, is that with New Orleans, with the exception, obviously there was some conflicts in certain ways, but in terms of people who were in, for example, the kind of relocation centers, there was a sense of unity because they were all in it together. Whereas the virus thing creates a sort of a suspicion, like it's almost like you're out in public, and if you cough a little, you want to be like, it's allergies. And I think what you're saying is spot on about the need. There does need to be social expectations. And so my point isn't that, it's bad to have standards for how people behave. I think you're spot on. But in terms of people coming together and having a sense of trust with one another, and really generally the comparison with that interruption of society in New Orleans, I'm curious your thoughts.
I think it's a little different in the sense that, remember when this first started, we had bad people. So there was this perception that if you looked, and some people so xenophobic that they couldn't distinguish a person who was Chinese from a person who would be Filipino almost. So when we started, we had bad people. The notion of bad people got reinforced when we started talking about the Chinese virus. So we started in a way in which, and this is similar to HIV/AIDS, we started in a way in which there are a group of people who are already condemned. And those group of people were seen as responsible. They were seen as spreaders. They were seen as the problem.
There were
And
attacks.
well, I'm sorry.
There were attacks even. Yeah.
No, yes, yes. And so what happens is that when you start with this very narrow vision of you already know who it is that you can get this from, you're so busy ignoring everything else that it becomes an us and them. So I think there are individuals for whom this virus and its spread is a burden because they are looked upon. It's not, and it's kind of similar to what you're saying is that you do that and everybody just jumps 10 feet away. But there are individuals who appear to be taking that burden because it's believed that they're probably infected. So we have ideas of who we think is infecting people. And even though I think we've gotten better, and it's just talked about less, when you see somebody who is a worker, I don't know if you know these stories, but sometimes the healthcare providers will tell you they're coming from work, they want to step into, some place to pick something up, like even take out food or something, and people right away know that they have been exposed and that they might be, one of the carriers. So it was why that there were people who stepped up. Sometimes they're medical students and stuff. They would go and prepare food, give them things because of the way they were being treated. So in this epidemic, when you start with a sense of blame, it makes it difficult to have this, we're all in this together. So instead, what you see is there's smaller groups that have this, we're all in this together. And that's what you see with first responders, and we're, high-fiving, being very good, but they experience that. And they also know what it's like to be scapegoated in this.
I think that's a fantastic point. To go a bit broader, though it connects, what do you think are some of the short and long-term psychological impacts that can occur as a result of social distancing and isolation at the level we've been doing it, in terms of mental health risk? I mean, even suicide risk, for example.
Right. One of the things I've talked about is, and I'm going to start with the long term and then draw it back in, because I think that's probably a way to kind of get a sense of the broadness of it. So as we get further and further into this epidemic, and we think that we're getting near an end of it, and we don't know whether it's going to be cyclical or not, I think what you're going to see is that as cities, quote, reopen, people are going to be psychologically starting out as they're already worried, but they're going to be kind of more, anxious, because we keep talking about returning. We keep using words like, are returning to normal, and that's not what we're going to face. This epidemic has changed us totally. And when I say changed us totally, it's not like the New Orleans epidemic, where what you had was this, we worry about these things every time the cycle of the weather comes up and reminds us that, we're going to have hurricanes. But we're going to change in dramatic ways. What has happened during this epidemic is going to change the workforce. We are very clear that jobs are going to be done differently. And with jobs being done differently, you're going to have a class of people who are going to lose jobs. You're going to have a class of people who may be very well off, but still won't make money at the same rate. And depending upon how long this goes, even for individuals of great wealth, the loss of some of that wealth is going to impact the way they can contribute to society, the things that they need to do, whether their businesses are going to change. So you're going to have people who are going to be devastated from the loss of income, from the change in their status in society, from the inability to be able to provide for their family. So I'm predicting that what we're going to see is a bit of a syndemic, not just an epidemic, but a syndemic. And in public health, we talk about syndemics when you're going to see probably a rise in substance abuse. And we kind of have even the indicators for that already, which is drinking is going up. So, and I think that drinking is more than just, the Zoom toast that we're doing, but it really is people drinking out of boredom, people drinking, people, trying to relax. So, what's going to be interesting is to see if we also end up in that substance abuse with there being drugs. It's a little harder right now because you just can't get drugs as easily. But whether or not
contactless delivery.
Well, it's interesting because there are restaurants that are doing cocktail deliveries, but I don't know of anybody that's doing drug deliveries. So, so anyway, once that access is there, and remember that access is actually going to can be twofold. That access will be prescription drugs, and we don't have as many reasons for the prescription drugs now, but once we get out and about, there might be, and then just illegal substances. So that may go up. The mental health problems we know are going to go up, and then we may also have a rise in suicides. So this epidemic, we need to pay attention and start to place the types of services that we need, because there's going to be a lot of people who right now are just home worried. But when they really get the news, probably what's going to happen is around the end of June, we can start looking for that, because that's about as long as some of these businesses can last, with having no business and then limited businesses. These institutions, like academic institutions, large businesses, they're going to have to make a decision around that time as to how to redo their workforce. So some people are going to find out that there's no more protections. The federal government is concerned about how many times it can do, the stimulus bills, the paycheck protection and things like that. I mean, there's one, the HEROES Act is sitting there with a $3 trillion price tag. So how many times that we can continue to do that is on the minds of the federal government, and they're wanting to move this to the states. States are already have billion-dollar deficits going on right now. So the reality is just going to get, more clear as to, major layoffs.
That economic impact doesn't just disappear once we quote unquote reopen. As you were saying, it's not really a light switch.
No, what's happened is that there have been a lot of stopgap measures put into place. So what you have are people who may be worried, but they are hopeful. So what they're hoping is that they're going to return to something. And unfortunately, some people have no return. And what you're seeing is that one of the reasons to reopen is that, some governors are, as a matter of fact, they're just outright, some have said they can't keep bearing the burden of the unemployment. So some people are going to find themselves out of benefits, out of interventions that will come in the form of, checks. And that's when a lot of this is going to hit. So there is no light switch to flip this time.
And, what you were saying also reminded me, that to use a metaphor, an imperfect metaphor, but that social trauma doesn't disappear automatically. It's quite similar, I think, to the limited stuff I know about psychological processing of individual trauma, right? That we would actually have to, as a society, recognize what's happened as a change and to move on, but to move on in a way that integrates that new part of our narrative.
Right.
into our lives.
You're because part of what happens at the end of epidemics and disasters is that people move from this state of as an individual and this acute stress disorder to potentially post-traumatic stress disorder. So this is elongated, so imagine kind of and you're being given all kind of advice: exercise, take time for yourself. I mean, we're in this now weeks, and we haven't even gotten near the end. And what's going to happen is that people are kind of holding this anxiety at bay. They're experiencing it, but they're somewhat trying to hold on. And then what's going to happen is it's going to reach a point where nerves are frayed, people are exhausted, there's difficulty in managing everything. You're watching people who, people are starting to have sleep problems. Some people, it first hit, when it first hit, people were like, "Oh, I got 8 hours of sleep." They were feeling wonderful. It was, everything was quiet. It was like the beginning of a vacation. But now we're getting to a point where we're overworked. We're, am I freezing?
No, you're all set.
Oh,
I was
sorry. I
you
thought.
inspired a question and I started writing something. No
Oh,
worries.
okay, that's fine. So we're reaching a point now where if you're working, you're almost overworked because everything takes longer. If you're not working, you're reaching a point where when you see the news at night, you're getting more worried. So we're entering a phase depending upon where you live in this country, we're entering a phase of post-traumatic stress disorder.
So, can we expect that populations in areas hit harder by COVID-19, such as New York City, might see more severe psychological impacts? Or, I mean, there is that balance, though, that a lot of the measures are generalized despite the hotspots. So it's both.
You know what? It depends. It depends on the response that's going on, that is that of trying to disrupt this. So if you look at New York, the governor was very smart. Cuomo called for volunteers. He included mental health providers in that. So he may be encouraging people to disrupt that movement from acute stress disorder to post-traumatic stress disorder. So we don't know. This is a problem. We don't know the numbers. But he has been great at having those services. So I think that it's not how severe it is in a place, but it will actually be the extent to which the ability to disrupt and interrupt it occurs in a place. So if there are services that you can reach out to, that's great. If there are people who have been mobilized as volunteers to be disruptors in your life, in the sense of making sure you're well taken care of and you don't feel alone and you don't feel panic about, the next meal for your family. If you're in a state where accepting things, such as being in the drive-through food lines and things, becomes more normalized and you're not feeling ashamed, then I think you will see outcomes will be different. So how it's handled on a population level is going to be critical.
And on that note, really, this whole thing has seemed to crack open a lot of fissures in terms of like general health inequities, what we might call background disease, the ways different people are affected differently demographically by not just COVID-19, but even you would imagine the way these lockdowns are enforced might be different. I mean, I'm in New Jersey, right? And this is anecdotal, but I've certainly heard that the way the lockdown was policed in Newark might have been different of an experience and more stringent than, if you go to an office in Princeton. So
Um,
do you see that population wise in a non-location but more of a demographic way that there might be differences as well.
I think that if we think about whether or not, let's say, the lid was blown off on this great secret around disparities and what happened in terms of those disparities, that's I think, a perspective that's only held by some. The individuals who live in those communities, who work those jobs, they've always known that
Hmm.
this was not fair, unequal. If I use the trite phrase, I remember on Twitter somebody said, please don't say it again, but it's like, when America gets a cold, these communities get pneumonia. So it's kind of like the reality of that, it has always been known in certain areas. But this is what's different. We do not have the ability in this epidemic to ignore those populations. It's not just that with policing, I can keep you in, these communities. Why? Because a lot of the individuals who are at the greatest risk, it's not just, see, it's interesting. And I think Secretary Azar commented, and there's others who commented, they keep pushing the notion that it's the health, it's being in bad health. No, it's being in bad zip codes. It's being not America's favorite people. It's being a group of people for whom society has neglected, forgotten, and sometimes goes out of its way to ensure that it will not have equal access to opportunity in this country. But with this infectious disease, unlike with HIV/AIDS, which was transmitted by sexual behavior, by needle usage, and for a very short amount of time through giving blood, this is translated in an aerosol manner. And you need somebody to be your essential worker. We think about the difference in the two epidemics is you can't just look at an individual's behavior and contain them, but because of the ways in which society, the very people who are bearing the brunt of this disease, are interconnected to others, you're paying the price. You're really paying the price for what's happening. We have healthcare providers who never intended to be, be infected, and they're going to do their jobs, but they're doing the jobs and being at risk because of the way in which society has treated certain individuals. We put people into jobs, for example, at board and care and nursing home facilities where they pay so poorly that the person is working at two of these, or the person has an additional job. So we've paid them poorly to take care of our, individuals who need to be in those facilities. And the result is they're then ending up bringing risk into that setting. Because we know that the elderly didn't start out with it. They had to have an exposure because they were in the facility.
Right. And I mean, there's been internationally, there was an article that came out about this with the UK earlier today, but this has been almost a universal theme, except out of a few select countries. The neglect that the nursing homes have faced when it was known months in advance that this would be a hotspot for transmission dynamics. And to your point about healthcare workers, I mean, it's one of the top fields in terms of childcare obligations. And so we're expecting all of this from them with schools closed as well. And so there's potential for labor shortages in terms of these healthcare workers even being able to show up. And then, of course, they're worried about their families with catching it.
Exactly. And again, when we do this good people, bad people, our healthcare workers were in the good people category. But the way in which we treated these people that we see as throwaways and easy to neglect, and we have all kinds of, marginalization issues, we now see that, it then puts other people at risk.
So is there any way to better prepare healthcare workers and really society in general to address these mental health concerns for future crises? I mean, I know we've really brought up in a way that the interconnectedness of everything. So I know you can't give a soundbite answer that's totally comprehensive, but I'm curious, and I'll just open the floor as well to your general thoughts on this as we close.
It's called prepare. One of the things that we have not done well is to acknowledge that in this country, there are cyclical disasters. So, for example, we know that there is a tornado season, there's a hurricane season, but yet our infrastructure treats it as, quote, an emergency in the sense that, the preparation starts when the season starts. We have to build a better mental health system that can surge with the demand that will be put on it. So, for example, it's, there are places where when there is an emergency, then they have a whole volunteer force that comes out. We have to think about what are the ways in a state, because I think part of it is we depend on the federal government. And I think we're learning that states have to take this on. So having in place a volunteer system of who can be called out, in mental health emergencies would be good. Having the ability to have in place community responses. So, for example, here in LA County, the mayor's office has a group of people who can be trained. And usually, what would happen is if there was a shooting or something in your neighborhood, they would be called in and they would help the neighborhood. The police would leave, all the external groups would leave, but you'd have somebody who was local to stay. So I think we have to rethink what it means to have mental health needs with the ability to surge when there are demands on them in the same way that we have those same plans for health. So you saw us move quite quickly with getting ventilators and things like that, that could take the surge in the hospital. We aren't looking for beds often in terms of mental health response. We're looking for people, we're looking for rituals, we're looking for support groups. And we need to just be able to call upon them because the infrastructure is still in place.
To just close with actually one more question, because I've been kind of peppering this into the end of all of my interviews lately. I think a mental health related one is perfect for it as well. With all of the challenges everyone's going through, I've just been asking, what's a positive experience you've had since this started, or something you're proud of in terms of the ability through your work to meet social needs?
Probably one of the things I'm quite proud of is that, I have a background as a researcher. I've worked for many years in all of these populations that are at risk. I've worked with Native Americans, I've worked with African Americans. So the groups that are most at risk, I know them well. And what I'm proud of is having had the ability to work with members of Congress on thinking about how to craft bills that, as we're trying to respond in this emergency nature, but how to craft bills that really will work. Just give you a quick example of something. When we're thinking about this real push to develop vaccines, I keep reminding people weren't taking vaccines before. We have a problem with immunization, and those problems are in, racial and ethnic minority communities because of mistrust and misinformation. So it's like being able to take that information and say, don't do a model of recovery that says these individuals are going to take the vaccine. You need to have a predictive model B that says they're going to be delayed in taking this vaccine. And what do you need to do to decrease that delay? So some of the planning activities that have been going on locally as well as state and federal, I've been able to contribute to, and that makes me happy because I'm hoping that that will mean fewer lives are lost in the very populations with some of the greatest risks.
And to your point about vaccines, before we finish up, I mean, it's the case that even now, the 13 ACIP recommended vaccines are not all covered by Medicaid in every state.
Exactly.
And
Exactly.
so there's a lot to deal with, but I'm glad to have people like you helping deal with it. Thank you so much for coming.
Thank you, and I appreciate that you see the importance of this, of these particular issues, and that you're going to share it with the public because you're part of what makes for a public campaign that helps to educate people. So, thank you for your work as well.
It's been a pleasure. Thanks.
Great. Okay. Thank you.